Hello. I'd like to say a few words about the hydrocodone acetaminophen issue. I think the major problem stems from chronic pain syndrome, which is a very difficult stage of the pain to treat. It requires high doses of opioids, and the mixture of the hydrocodone with the acetaminophen does not sit well with that program. The stage of chronic pain and acute pain, the acetaminophen would be appropriate, but it's not appropriate with the hydrocodone in the chronic pain syndrome stage, which is the exhaustion stage of the general adaptation syndrome. If we had the hydrocodone alone without the acetaminophen, we would have another medication that can be used. And with the shortage of opioids appearing in the market, I think it would be beneficial to have the hydrocodone alone. The acetaminophen hydrocodone combination would be just fine for individuals with chronic pain or acute pain, since they can be controlled rather easily. I have made an illustration to show the differences in this. The illustration is the pathophysiology of pain, which was developed initially by Hans Selye back in the 1930s, and pretty well developed by the 1950s. It has the stages, the acute, the adaptation, the exhaustion stages, and either recovery or death. And it's this stage of recovery or death that is the problem. I'll point out these stages in this illustration. This is the opioid level needed to suppress pain. And here we have the opiate level, which is the drug level to relieve pain. And if a person is injured and goes into pain, the acute stage, the opioid level, will rise, and if the treatment is successful, the opioid level will drop to its homeostatic level. It's always some present. But if the treatment is unsuccessful and the person goes into chronic pain, then the opioid level needed is much smaller than it happens to be when the person arrives at the stage of exhaustion. At this stage, the body is no longer able to produce the opioids, which is what this line depicts. They're no longer able to maintain the opioids, so to shore up the opioid level, more is needed here. Quite a bit of difference, which leads to a lot of problems. Individuals are afraid to provide the patients with this much medication. They wind up oftentimes repeating visits to emergency rooms, going to the street to buy drugs, not knowing how to take the drugs when they get them on the street because there's no prescription with them. And if they get the long-acting or the sustained-release medications mixed up with the quick-acting medications, if they were taking the long-acting ones in place of the short-acting ones, as though they were short-acting, then the drug piles up and can pile up very quickly and be very lethal. So these are precautions that are needed. These people are out on a limb trying to get their pain managed, but I'm sure that a good deal of the deaths we see with the opioid overdoses are related to that inability to take the right dose or and getting drugs off the street. Now, they shouldn't be having to get these drugs off the street. If the doctors would treat them properly, we would not have that problem. And in 1987, it was discovered that the doctors were a big problem by not treating the patients adequately, leaving them out to wander off for themselves and getting into trouble. This was, they wind up going to the emergency rooms frequently, trying to get medications, and found that a new name was provided in 1987, a pseudo-addiction. And it's clear now that any statistics that has to deal with addiction has to consider whether or not pain was involved, in which case it most likely is pseudo-addiction and not addiction. Therefore, any statistics that only mentions addiction and comes out with numbers without comment about pain is invalid. The process that begins with pain involves genetic changes. And these pictures depict the genetic change that takes place in over about a 6-month period. Usually it takes about 6 months for pain, persistent pain, to convert the brain from one stage to the other. CFOS is one of the immediate early genes that appear. It may well be that the sequence of immediate early genes that do arise may reach a point where we can use that point as a biomarker for the diagnosis of chronic pain syndrome. The other thing that develops, which I haven't mentioned here, is the hypothalamus swings into action with the onset of pain, putting out ACTH, actually putting out pro-opiomelanocortin, which has ACTH, endorphin, MSH, LPH in them, indicating that we're going to have involvement of the immune system and also the involvement of the GI system, and then things become complicated and the whole body starts to collapse, and that's part of this exhaustion here. All the organs are now involved in a degenerative process and can very well lead to death, either by the disease itself or by suicide, because people in this stage are frowned upon, they're called addicts, they're socially outcasted.